All right, so that's the basic of the elements around the cells that facilitate depolarization. Now we want to talk about the cardiac action potential. The cardiac action potential is really where the work is going to be done for pharmacology and even understanding later electric treatment and therapy for patients with heart problems. The cardiac action potential, as you see here, looks essentially the same as it did when we looked at the skeletal muscle. And there's a reason for that. I kind of utilize the same source. And so it gives us a list of things that we can determine on this waveform that are occurring to complete the depolarization. Again, this is for depolarization. Now, this is not an EKG, but it does relate to an EKG. And remember, this is basically measured inside a single cell, inside one cell. When we measure somebody's electrophysiology in the pre-hospital setting and in the hospital setting, we use electrodes on the outside of the body. And those electrodes will feed to a monitor that shows us our waveform. Now, we're not going inside the cell to make these measurements. So we're going to have to extract later what from an EKG tells us about this occurring in the cells in the region that we're studying at that time. So let's go through these steps. Obviously, the action potential basically starts with a resting membrane potential that's lower than zero, that's negative essentially. And in that negative charge, it's because relative to the outside, there's more sodium on the outside of the cell than there is potassium on the inside of the cell, and that gives us that membrane potential, just as it did in the neuron and just as it did for skeletal muscle. So what changes is phase 0 is now after the last phase 4 kicked in, which is basically the resting membrane potential. Phase 0 occurs for rapid depolarization, and essentially what happens here is sodium channels open and rush in. As sodium rushes in, it causes the inside of the cell to go more positive, so we're crossing the 0 threshold and we're into positive millivolts. As we get to the peak, the sodium channels are going to start to close. Now, in the nervous system, we saw the waveform basically decline right through here. And that was to indicate that sodium and potassium were the only two major ions present. But in muscle, we utilize calcium. And calcium plays a role not just in contraction physically, but it increases the length of time that the depolarization is going to occur, allowing time for contraction, hopefully, to happen within it. And remember, contraction doesn't automatically happen with electrical conduction. Pulses of electrical activity happens and often is a very beautiful EKG, but has no perfusing pulse pressure. During phase 2, calcium channels are going to open, and that releases the calcium from its storage site inside the cell, and that will travel to the points of access for troponin, then moving troponin and tropomyosin out of the way if we have contraction occurring. Now, during phase 2, again, it's a positive charge that we get elongated so that we have time to do physical mechanical work. Phase 3, a few things are going to happen. Calcium channels, they opened up here. They're going to close here for phase 3. Phase 3 also has potassium channels open so they can rush back into the cell. And we're trying to get back to the threshold potential or to the period between action potentials. By phase 4, we're basically ready for another depolarization to occur. The threshold potential we're going to review as part of the absolute and relative refractory periods that occur as the cells move ions into the right location so we can get ready for the next depolarization. Now, each of those phase sections are here, and they will mimic exactly what we'll be discussing in the pharmacology course next semester. So memorizing them now will certainly help you for that term. Now, this slide, though, is a little extra for us. I include this slide because it helps us understand the waveform that we just saw isn't just purely for a thought exercise. It's to basically help us understand what physical, actual things are occurring inside cells that maybe we can manipulate when patients have disorders that are involving depolarizing cells. So if we look at this as the cardiac depolarization cycle now, again, phases 0 through 4, so total 5 phases. 0 is sodium depolarization. 1 is sodium basically channels close, and potassium and chloride will leak out a little bit. The phase 2 is going to be the plateau, in which we have calcium channel release and calcium now flowing into the cell for contraction, if that's still going to happen. In phase 3, we have closing of calcium channels, opening of potassium, so potassium can go in and out to the appropriate concentration, and eventually potassium will return and allow for us to have a more negative charge inside the cell compared to the positive charge outside the cell. So for each of these things that occurred in each phase, there are drugs that can be used as antiarrhythmics to try and change a arrhythmia through the mechanism of the cell function. And so these are chemicals that we're giving to the patient that will change how the cell does all of these different steps. Okay, so we understand how now one cell depolarizes, right? One cell depolarizes and gives us this plateau waveform. Now let's look at how we measure that external to that individual cell and get information from the surface of the body about the functioning of the heart as a whole. Now, the electrophysiology of the heart, you already learned the majority of at the ENT basic level, and hopefully you've retained quite a bit of that. So some of this will be a review. Let's just jump to it, though, as if we're talking about it for the first time. So the normal structure and function of the electroconduction system of the heart is basically baked into the myocardial tissue, right? It's kind of it's integrated. It's not necessarily a bunch of wires like our diagrams or us imagining how electricity works would tell us. Instead, the cells have particular characteristics that allow these things to occur. So the structure is, and on this first slide here, I'm going to give us a few more things that we'll write down as important notes for you. So stay here to make those notes. So the SA node, if the heart is functioning normally and is healthy, has no issues with the conduction system, the sinoatrial node will be the point that our electrical impulse for the entire heart will come from. And so it serves as our primary pacemaker. Now I say primary because the other things listed here are backup pacemakers if the sinoatrial node or the thing that it's receiving the electrical signal from is no longer communicating. So it serves as backup pacemakers. The sinoatrial node gives rise to the term a sinus rhythm. We'll find that the sinoatrial node is associated with the P wave. And again, we'll review that in a moment. Now, if the sinoatrial node is functioning normally, it generally beats at a rate of 60 to 100 beats per minute in the adult. If you think of vital signs, how we would measure, not electrically, but measure whether or not blood is flowing through a person's body, we would do so first by checking a pulse. And so that happens to be the normal adult pulse range as well. Now, the sinoatrial node can beat faster or beat slower to meet the needs of the body and the environment that the body's in. But in general, functioning, this would be its normal range. How convenient, right? Now, the AV node is our secondary pacemaker. And as a secondary pacemaker, its primary role is actually just to receive the electrical signal from the SA node and hold on to it for a few microseconds before sending it down to the ventricles. We'll talk about why that pause is important in a moment. But if the AV node doesn't receive a signal because the SA node is sick or dead, it can then create its own beat with one of its characteristics. And so in doing so, if it becomes the primary pacemaker, right, the secondary backup pacemaker, if it's the area that's originating our beat, that beat's going to originate at the bottom of the atria and not the top. So that's a change right off the bat. And its range is 40 to 60 beats per minute. Often, if the patient has the AV node as their primary site of electrical impulse origination, they're likely to have some form of bradycardia. The AV bundle is the section attached to the AV node that then crosses from the atria to the ventricle. And again, remember the atrioventricular space is connective tissue where the valves are. And so electricity doesn't automatically go down into the ventricles like it did traveling across the entire atria. And so through the AV node and traveling then to the AV bundle, the bundle of his, and then our bundle branches left and right down the septum, further depolarization and conduction of electricity towards the ventricles will now happen. Now, the Purkinje fibers are our tertiary pacemaker. And so if the primary and secondary pacemakers are not sending a signal, the Purkinje fibers, which are basically embedded at the terminal end of the cells in the ventricle, they allow for the actual contraction of the ventricles to occur. So if they're healthy and can generate a coordinated beat, they would generate a beat that's somewhere less than 40 beats per minute. So very, very slow. However, it does happen that instead of less than 40 beats per minute, we end up with something that is really, really fast. We wouldn't call it tachycardia. We would call it fibrillation, in which every Purkinje fiber in ventricular fibrillation, every Purkinje fiber is firing independently and not in a coordinated manner. It makes for a very chaotic ECG rhythm, but does not allow for perfusion because there won't be full contraction of ventricles in an organized way. So that's kind of the layout of the major components of this. And there's definitely subdivisions that we'll get into in the cardiac theory course, but this is enough for our understanding for the moment. So in this picture, we can see that laid out across the heart. And again, it looks like there's fibers, but really these are just cells with unique characteristics that are traveling in this area. The SA node is a collection of pacemaker cells, and the cell that has generally the strongest and the fastest beat among the collection of cells that are pacemakers, that one will be the beat for that cycle. And so the SA node, when it depolarizes, will send electricity from the top down of the atria. The AV node holds on to it. More on that in a moment. After it has held on to it for a few milliseconds, it will release the depolarization down through the septum, the bundle of His. This is a bundle of His, or the AV bundle, down to our bifurcation into left and right bundle branches. Again, still mostly conducting electricity with a few of the other fascicles branching off, doing some of the work, and finally moves to the bottom where Purkinje fibers now are embedded inside the wall of the ventricle, and the electrical impulse will move from the bottom up. And why is that important? It's important because if you just look at the structure of the valves in the heart, the ventricles have valves at the top of their chamber. So they have to squeeze from the bottom up to send blood into the valve and into the blood vessel behind it. The atria, though, they're really just draining essentially into the ventricles, and so they're moving from the top down. Now, if they both, since we now know that they kind of work in opposite directions, if both the atria and the ventricle squeeze at the same time, they would be competing for each other. And blood would not necessarily go into the ventricles. The ventricles would squeeze blood out, including back into the atria likely, before it received the full volume. And so it's really important that there's a separation in that. And we'll find that as basically a flat line in between some of our waveforms. So now that we know the structures, let's look at how each part of a EKG waveform now applies to this area of cells. We measure those waveforms using electrocardiography, and that's essentially just the study and measurement of electrical conduction through the heart. And we have this as a representation in the name, basically, as a graph, and we'll define that in just a minute. So the ECG is utilizing electrodes that are sensitive to electricity through our skin that report back to a microprocessing unit in a cardiac monitor or even an AED if we're talking about pads, and that device will take measurements of the electrical information it receives. Now, an ECG that you learn at the EMT basic level or even at the EMT intermediate level is really still just talking about your ability to look at a waveform if it's present on an AED, and then maybe gathering information so that you can transmit and learning to do a 12 lead so you can transmit it but not interpret it on the scene. As a paramedic, you need to make those interpretations, and it's not a good idea. It's subpar for you to rely on the ECG's diagnosis. You need to have your own diagnosis because the ECG could be wrong, especially if electrodes are placed and the person has abnormal physiology to begin with. So the ECG with that external measurement is, again, another tool, but by itself, if the ECG reading, after we do, say, a 12 lead, tells us that the person's having a heart attack, they still may not actually be having a heart attack. So again, we treat the patient, not the sign itself. Excellent. By the way, it doesn't matter whether you call it an EKG or an ECG. The kind of German term would be for a K, electrocardiogram, and the C for the English term. But it doesn't matter to me which one you use. So now let's talk about some of these waves. This should be a review, but we'll get a little bit more depth out of it now. So we're going to review the waves, what's happening inside the heart, and what's normal to be present. At the end of this, we'll look at an ECG tracing and try to extract from that what that rhythm might actually be called. All right, so let's dive in. In this picture, we can see a set of different stages from 1 through 4 that show the start of an ECG depolarization and end with repolarization of the ventricles. And so if we look at our normal waveform here, we can already identify what's happening in the heart by just knowing what this waveform is. This first waveform that we encounter is the P wave. The P wave is associated with the sinoatrial node, so if you have a P wave, the sinoatrial node is likely the origination of that beat. It's firing. And so if that's present, we would say it's a sinus rhythm. In fact, the typical ECG that we learn from, the healthy ECG we learn from, is called a normal sinus rhythm. And then, of course, there's variations like sinus tach and sinus braiding. But if it doesn't have a P wave, it can't be called a sinus rhythm. As the SA node depolarizes, we get our P wave, and as the depolarization travels through the entire upper portion of the atria downward, again, top down, the AV node is going to hold on to that signal. Again, doesn't allow it to go into the ventricles until we've had some time. That's actually represented right here by the AV node, basically creating the PR interval. Now, the PR interval is the space between the P wave and essentially the QRS complex. And that interval is essentially telling you how long the AV node is holding on to that electrical signal before it depolarizes and sends it back through the rest of the heart. Now, it's important to know that you should be measuring your PR interval when you get to the level of doing 12 leads and operating as a paramedic. But at this point, we're just talking about the concepts. I'm not going to give you actual measurements. But know that if the PR interval is elongated, that means that the ECG tracing will be longer over the x-axis, time. And as it gets longer, that means there's room for less of those beats every minute. And so elongated PR intervals often have associated with them, or abnormal PR intervals may have associated with them, something called a AV, because of its location, heart block. Usually these are described in degrees. Again, we're not going to get to that level right now, but you're getting the basics to understand that. As the PR interval comes to a close, the first downward waveform that we see is called the Q wave, and it's not always present. In fact, it could be normal that somebody doesn't have a Q wave and they transition directly to the R wave. But a really deep and wide Q wave may actually be pathologic and indicate that there's some prior disease present and maybe some significant damage to the heart. The Q wave is basically showing the depolarization through the start of the septum. The R wave, the stroke that goes up, the R wave is now showing us the rest of the depolarization of the septum and now moving towards the Purkinje fibers. As it goes through the septum, the walls of the ventricle do not yet contract. They haven't received the signal. So as we go through the S wave, or the downward wave after the R wave, we're now going to be moving up the walls of the ventricle. And as the electricity runs up the walls, it stimulates the Purkinje fibers, and by the end of the QRS, our ventricles have contracted. Finally, repolarization occurs with our T wave. The T wave represents ventricular repolarization. Now, why don't we see, if there was a atrial depolarization, why don't we see repolarization of the atria? Well, it does happen. It's just that there's less cells in the atria compared to the big old muscle cells of the ventricles. So right off the bat, our ventricles have much larger amplitudes of electricity because there's just more cells doing it. But inside the QRS, that's where the repolarization of the sinoatrial node, basically reversing the P wave, that's where the repolarization occurs. So it's buried in there, but not as strong as the QRS, so we can't see it. The space between the S wave and the T wave is the ST segment. Now, the ST segment, maybe right off the bat, brings off this idea of a STEMI. ST elevated myocardial infarct. Now, that is a finding that can be indicative of a myocardial infarct, but we can't just measure it by seeing the ST segment go up. There's parameters and measurements and points that have to be taken into account because, in fact, there are young, healthy adults, a lot of them, that have early repolarization syndrome, and the T wave moves closer to the QRS, and because of that, it looks like it may have an elevated baseline. So the ST segment will take some measurements. But yes, if the ST segment is elevated and the patient has that in the presence of a heart attack, it's indicating that their heart attack is severe and probably in the early stages of ischemia. As the ST segment changes, if the ST segment goes down, often that may indicate that the person has infarcted. That tissue now is dead and not likely to return. Yeah? I want to tell you about how do we get this tracing, right? It is possible that this tracing could look different if we had a different view. So when we're looking at this EKG, and until we tell you otherwise in training, when we're looking at EKGs, we're going to be referring to the ECG in the view of lead 2. Now, lead 2 is very particular. Most cardiac monitors are set to default to that view when you turn on the LifePak or Philips device or whatever it is that you're using in the field. It should show lead 2 right off the bat. It may be programmed to show other things. Lead 2 is kind of our orientation to things. So when we put lead 2 together, we're doing so in a 3 or a 4 lead. It's present in a 12 lead because the 12 lead builds upon the 3 or 4 lead. So just doing a 3 lead or 4 lead ECG, not a 12 lead, will give you the view that you need and still is relevant as our kind of orientation. Now it's helpful because the eyeball or the camera, if you will, that we're looking through for lead 2, that camera is looking straight down the center of the septum of the heart. And so it's somewhere above your hip and looking straight through to your shoulder. Again, down that line when we separated our heart into left and right halves. There's our beautiful Valentine's Day heart. You get the idea. So when we're looking at this, some distinct things happen. The electrical impulses that we see on an ECG, if they go upward from the baseline, they're generally moving toward us. And if the waveform goes down, it's moving away from us. So let's see if that's true. If we're looking with our eyeball at the apex or the fifth intercostal space, midclavicular line, looking straight up the center of the heart towards that right shoulder, what should we see? Well, the SA node depolarizes and sends the signal down from the top. That's toward us, so the P wave is positive. The Q wave is a little different. There's some contraction and change of directions that go almost horizontal here as we transition from the AV node into the AV bundle or bundle of His. So we can see a downward moving away from us. And then the R wave is really big and moving towards us, right? That's important because that's the electrical impulse going down the septum, moving directly towards the apex. And then as we get ready to contract, the electricity goes up along the walls of the heart, and we see that as moving away, or our S wave. And so, in fact, we do see that the positive inflections are moving towards us and the negative are moving away. Now, what happened if we maybe put our eyeball up here or our camera up here? And we looked exactly the opposite, from the shoulder down to the apex. Well, the same thing would be true. In fact, this ECG looks basically like an upside-down image of the lead 2 ECG. Whereas the P wave depolarizes and moves away, so the P wave is down. The Q wave maybe towards us, the R away, the S towards us again, and repolarization. So you have to orient yourself as to which lead you're looking at. And when you look at an EKG, every lead is a different camera angle, including the 12 lead. You get 12 leads out of a number of leads that you place on the patient because of the alternation and the electricity to each lead to take that picture. Realize, though, these are all looking at the exact same thing and often looking at them at the exact same time. But we start with lead 2. So what do you do with this knowledge, right? I just taught you all these different parts of the heart that are associated with each ECG, but I didn't tell you really how to then take that to the next level. Well, right now I'm going to show you how to read an ECG basically. And this kind of follows the steps that are in your paramedic textbook. I've left some things out here because we haven't talked about the intervals for measurement. And so we'll do the same order of things. We'll just do them to a different degree once we learn those in cardiac theory. So the first question to ask is, what are the waves that are present? Can you identify a P wave? And is there a QRS after every P wave? And can you see a T wave? Are there, in one cycle, do all of those occur? After you've identified the waveforms, now determine the heart rate. There's a few ways that you can do this, and I'm just going to give you the least effective but the fastest method. There are more precise methods of measuring this, but this is just for our introductory section into cardiac. To get the right measurement from an ECG of beats per minute, and again, they could be none that are perfusing, so we can't relay that as a pulse by itself, you can print off a 6-second strip. And most ECG paper is marked at the 6-second point. The 6-second strip is utilized to take a snapshot 6 seconds long. And so the number of beats, generally of QRS complexes you have in that 6-second strip, you'll multiply by 10 to get your at least introductory heart rate. So if there's 5 QRSs in the 6-second strip, that would be 5 times 10 and a heart rate of 50. Again, it's really for broad strokes, so it won't be as precise as some of the other methods. You're trying to get from this, is it fast, or is it slow, or normal? That's what we're looking for right now. Now, let's look at the P wave. If there is a P wave present, then we can call this sinus. Sinus something after we get through the rest of the qualifiers. When you learn how, you'll want to measure the length of the PR interval to determine whether or not the AV node is dysfunctioning and causing a heart block. Next, you'll want to ask whether or not there's a QRS for every P wave, or are there less P waves or more P waves than QRSs in the representation you're looking at. If there are not QRSs after every P wave, it's a signal that the SA node is working, but the signal is not getting to the ventricles, and the ventricle may be doing its own thing. Also ask ourselves, is the QRS wide or narrow? And for right now, I'm not giving measurements, so get a feel for wide and narrow as kind of broad strokes. If it's wide, it generally means it took longer to go through the cycle of depolarization, and they're both measuring the same thing between wide and narrow. So let's list it. If it's wide, longer to get the electricity through the same area that it would if it was narrow, and that generally means that it's originating in the ventricles. So a very wide rhythm is likely ventricular. In fact, the widest rhythm that I can imagine that we have perfusing is ventricular tachycardia. If the QRS is narrow, as it likely should be, then that means it was a short depolarization through the section of ventricles, and that means it originated above the ventricles. That may have been in the SA node, that may have been the AV node starting its depolarization as a backup pacemaker. When you get to the level of learning the values, you'll want to measure the width of the QRS to determine whether or not there's a block or a problem getting the electricity from the top to the bottom. And then look for a rhythm. Is the rhythm regular or irregular? Is it irregular but still has a pattern that's not normal? That would be called regularly irregular. It's not the normal regular pattern that you expect for this rhythm. It is abnormal, but it does happen with regularity. There's some type of cycle that's occurring. If there's no cycle, it's irregular, and there's no cycle whatsoever, so it's irregularly irregular. That can be indicative of a patient experiencing specifically atrial fibrillation. Great. So let's use those steps to go through identifying the 4 ECG tracings that I have here. And just assume that they are 6-second strips for our purposes. So we're going to start with A. So let's go through the steps. Let's see, I could probably write them down the side here. 1. Identify the waves. Okay, so let's start with the first one that we can see in total. Right, kind of here. So I see a P wave, there's a QRS, and a T wave. And it looks like all the others have that same morphology or shape. Okay, great, that's a good start. 2, let's determine the rate. Again, 6-second strip is all we're going to do for now. So 1, 2, 3, 4, 5, 6, 7, and 8 QRSs. So that would be a rate of 8 times, since it's a 6-second strip, 8 times 10, a rate of 80. Okay. Next, let's talk more about that P wave. We have a P wave, so that means we can call this sinus. Later we'll be measuring, but for now we'll move on to the QRS. Is there a QRS after every P wave? It does appear so. Excellent. That means that electricity is going from the top to the bottom, as it should. Next, is the QRS wide or narrow? Here I would say this is narrow. And so if it's narrow, it's a clue that this is in fact originating above the ventricles. So if we think that the P wave is working, and here we do because there's rather we think that the SA node is working because there's a P wave, then it's probably just reconfirming that. But if we have an SA node and a wide QRS, there may be other pathologies at play. And then finally, 6, what is the rhythm? And I would say that this is regular. The difference in space between each R to R peak is about the same. That's a good indication that it's regular. So I would say that this originates in the sinus node. It has a normal rate for the sinus, that's 60 to 100 beats per minute, and I don't see any other abnormalities associated with it. So this becomes a normal sinus rhythm. That's our baseline. All right, let's look at B here using the steps below. So first, let's look at the waveforms. Can you identify all the waveforms here? If you don't see one of the waveforms, just start with what you think you recognize. Okay, I think there's a QRS here. I think there's a QRS present. Looks like a T wave present, but I don't see a P wave. So if there's no P wave, can I call this sinus? No. And there's some problems with that because if I don't see the P wave, the SA node isn't working. And so the heart's having to rely on backup systems. All right, so that's a bad sign already. So we don't have all the waves. We've identified what we can find. Let's look at the rate. Again, 6-second strip. 1, 2, 3, and 4. So that looks like a heart rate of 40. Now, if the SA node isn't beating and a backup pacemaker is generating the beat for us, it'll probably look pretty organized and maybe even normal. But again, if we use the AV node or Purkinje fibers, they beat far slower than our SA node does, kind of giving us the idea that this is in line with that. Now, if there is a P wave, are there QRSs? Well, not the case here. It's still a big problem that there's no P wave. Is the QRS wide or narrow? I would say that this QRS is probably still a little narrow, but it's starting to get wider than the ones we saw above. And so that's an indication that it's not coming from the highest point, or the SA node. And so this would likely be a bradycardic rhythm. Where we're originating this beat may be associated with the junction between the AV node and the bundle of His. And so there's a few ways that we can identify this, but for right now, we're just going to say bradycardia. We're not sure it's a ventricular originating beat because the QRS is still probably just on the edge of being narrow. All right, let's go to C and let's go through the steps again. All right, first, let's try and identify our waves. So there's a P wave, there's QRS, and a T wave, and then this wave. All right, let's go to something we recognize. P wave, QRS, T wave, and that wave. Okay, that's odd. P wave, QRS, T wave, and that wave. All right, so what is this wave that we're seeing here? Is it a U wave? Not likely. So what we're seeing here are P waves that don't all have QRSs after them. All right, so we've identified most of the waveforms, and we seem to have P waves that are more abundant than the QRSs that should follow. All right, let's move through this then. So let's determine the rate. Again, 6-second strip. Let's look at the QRSs that are present. 1, 2, 3, 4, 5. So it looks like this is a heart rate of 50, roughly. Now we're looking for that P wave. Is there a QRS behind every P wave? P wave, nothing. P wave, QRS. P wave, nothing. P wave, QRS, P wave, nothing. So every other P wave is not generating a QRS impulse. So that's a concern, because that means that for some reason the electricity is not making its way and causing the Purkinje fibers to receive that signal. And so contraction is likely not going to occur. In fact, with a P wave and no QRS, there won't be any contraction that we can sense, because the atria aren't going to generate a pulse that we can check externally. Okay, so we're now concerned, and we see that although there is a P wave, that shortage of other P waves is likely identifying some pathologic cause. And so this is likely associated with a heart block. Just roughly and just superficially, we can say there's a blockage of information, the electricity going from the SA node to our QRS, or septum and ventricles. Now let's still look at the QRS. Is the QRS wide or narrow? I think it's still along the narrow range. And so that doesn't surprise me, because I can see that when the SA node does cause a QRS, it almost looks normal. So the problem isn't necessarily that I have a beat originating in the ventricles. It's that the ventricles are waiting for a beat that never comes. And then the next time they get stimulated, they receive the beat, so they never start their own contraction. So this is still likely a bradycardia associated with a block. Now let's look at this last one in the lower right corner. So let's still try. You might right off the bat be able to recognize it, but let's still try our steps. So number one, can you identify waves confidently? Probably not, right? Because we're seeing a lot of different waves, but none of them seem to organize into the QRS. And so what we're really seeing here, we're not seeing P waves. We're seeing more like all QRSs of varying width and height. Now that's a problem, because again, if there's no P wave, it's coming from the ventricle. This is, let me get through our steps here, but this is likely going to be a ventricular rhythm. So now let's go through our rate. A lot, right? That's really fast. And I'm not sure which ones are actual QRSs and which ones are not. So I'm just going to say it's really fast. Now we look for the P wave, and is there a QRS that follows? No. So we're getting a hint that, again, this is coming from below the atria. And it's a QRS wide or narrow. If these are QRSs, they're really, really wide. And so another indication this is coming from the ventricles. Is there a rhythm? Is this organized? It's really not. It's pretty chaotic. And so if all I have is a chaotic rhythm, that might be a candidate for ventricular fibrillation. And that's the case in which the ventricles are just kind of rumbling. They're not really squeezing, because Purkinje fibers are all firing in an uncoordinated manner. So this would be ventricular fibrillation. Would you expect to see a pulse with this? No. Could you see a pulse with all these? Yes. Could you also have PEA? Yes. And so again, underscoring that the electrical component is not always the same as the mechanical component. All right, so since we talked about a heart block, we can kind of mention a little bit about that dysrhythmia now here in a little side note for us. Again, just getting to understand some concepts, not ready to diagnose things. A cardiac dysrhythmia can kind of come in a variety of senses, and we generally find them by going through a stepwise process and reading ECGs. But what prompts us to put in ECG is probably history, signs, and symptoms. A patient that has a heart block, when we use this term, it's basically a block between the atria and the ventricles, making it so that any depolarization of the SA and the AV node is not going to make it to the ventricles in the same way it should. And there's a few different degrees, like literally a first degree, second degree, type 1, type 2, so on, and a third degree of these blocks. Not for our purposes here, but again, the worse the block towards this third degree, the more blocked it is. And so at some point, the ventricles will have to beat on their own, because even though the SA node may be creating a beat, it never makes its way down there because there's a block in that tissue. Now, this can be treated by implanting a pacemaker. Sometimes pacemakers are implanted just for one node site, or atria versus ventricles. In other cases, they may have an AV pacemaker in which they have two probes, one going into the ventricles and one going to the atria, to stimulate them both to beat if a beat is lost. Here's a picture of a pacemaker implanted in the chest. Older versions, there are still, I'm sure, that some that are implanted that look like this, but older versions were located in the upper chest, and it's about the size of a deck of playing cards. You should maybe remember that from your CPR section. And that indicates that the person has at least a pacemaker or a defibrillator. Sometimes it's hard to tell. I'm not sure if you can see in this picture, but this actually has two chambers. It has an electrode going to the atria and to the ventricle as well to allow for pacing of both at the same time. But now they can place pacemakers elsewhere in the body, sometimes in the abdomen, so that they're not visually as easy to identify. Either way, if we do have a patient that has a pacemaker and we need to do something like defibrillate them, just remember you want to be at least 1 inch from the device or metal in general in the patient from your pad. So just move your pad for defibrillation on the AED so that it's at least 1 inch away from that device. Sometimes it kind of seems like, why would we have to do that? Why would we have to use an AED on a patient that has an implanted defibrillator or has a pacemaker? Well, these things don't always work. They're not perfect, and people's hearts change even after they have these installed. And so it's a clear indication if they have a problem that we're seeing that their device should be taken care of, and it's not taking care of it. And it's our job then to take over so that the patient can survive to surgery where they can figure that device out utilizing the appropriate team. Some more terms for us, just loose terms. I'm sure you're aware of them. Bradycardia, tachycardia, sinus dysrhythmia. So normal sinus rhythm, again, is a P wave that has all the normal characteristics of the beautiful ECG we're looking at. A sinus dysrhythmia has some type of variance in its ECG waveform, but it still has a P wave. And so specifically, a sinus dysrhythmia can come from the heart rate changing because of the pressure inside our chest when we're breathing in and out. Sometimes there are ectopic beats, just like you've heard of an ectopic pregnancy, right? We have pregnancy developing outside of the normal location and implantation somewhere other than the uterus. So just like that, being planted somewhere it doesn't belong, an ectopic beat is a beat that doesn't fit the rest of the beats around it. And so often a very easy example of this is the PVC. Now there's also PACs and PJCs that we'll learn about, but these are beats specifically in the PVC, premature ventricular contraction, that the ventricles just send off. They just beat on their own randomly, it seems, compared to what maybe the SA node and the rest of the heart is doing. And that's usually an indication of some type of irritation. Often it's a volume of fluids, so IV fluids could be helpful to it, O2, and electrolytes. Fibrillation as a term is the term we just used for ventricular fibrillation, earlier used for atrial fibrillation, in which the chamber doesn't beat in a coordinated manner. And so it kind of just jiggles because all of the individual terminals are just firing on their own. And so it just kind of wiggles. It doesn't fully contract. And so that causes a problem. In atrial fibrillation, our big problem is that it's likely to allow a clot to form, which will then travel to another part of the body. And in ventricular fibrillation, they're in sudden cardiac arrest. All right, great. We're making great progress. Now let's go through gross heart anatomy.